As dermatologists, we often serve as the first identifiers of what's going on in a patient's internal organ system, body, as well as what's happening, of course, in their skin, hair, and nails. And today I'm pleased to have a group of leading expert dermatologists to talk about how diagnosing skin diseases of both the skin, the hair, and the nails can actually help us to better understand what's going on with a patient as a whole. We're going to talk a little bit about skin signs of systemic disease and also how other diseases, particularly inflammatory conditions, metabolic conditions, even malignancies and cancers can affect skin, hair, and nail changes. And to lead us off, I'd like to talk to Dr. McKinley Grant a little bit about how inflammation can be perceived when we're talking about skin disease.
So one of the most important things that dermatology, I think, contributes to medicine is the ability to make an early diagnosis of some very serious diseases that are infection, which is exhibited by inflammation, cancers, and we can see the very, very early signs. And one of the very early signs is redness in the skin, which we call erythema. It's always a big word, but it's just redness in the skin that is affected by a person's blood count, and it's affected by how much oxygen they have in their blood. It's affected by also whatever is going on in terms of the inflammation of the skin. And it comes up as it's erythema means red. It comes up as red, but if you mix in melanin, which is a brown or black, and you mix in other colors, you get varying shades of red. So I always think of like a paint chart, you know, painting a room. You get a ruby red, you get a purple, a violaceous, as we call it. And the important thing is to diagnose these things, the erythema, early. And it takes a lot of training. You have to train on dark skin to really be able to detect it. Frequently, people will say, oh, I don't see anything. The patient will say, you can't see this, it's red, my hand's red, it's painful, it's swollen. So you do have to touch the patient, you have to see if there's any warmth there that's going along with the redness. And it's, you know, early detection of the redness and knowing how to recognize it is very life-saving in most cases.
So it sounds like what you've really described here is something that's very nuanced, that has a lot of different presentations, a lot of different appearances, and you really have to have your eyes and your clinical acumen trained to pick up on those signs. And what you're saying is that inflammation, if you catch it early, you may be able to prevent some long-term sequelae, it sounds like, of some of the things that we're talking about. And I think you're right. I think inflammation in skin disease is so important, specifically when we're talking about outwardly facing skin diseases. I know, Dr. Perez, you treat a lot of patients with inflammatory skin diseases. Can you give us some examples of maybe clinical conditions where you've actually seen patients who have been suffering from inflammation, from some of the signs and symptoms of erythema or redness, and how that's presented?
Yeah, it's very interesting because you have erythema and you have erythema. You know, there's different gradations as we are discussing here. So when you have little erythema, still in a patient of skin of color, that erythema always translates into hyperpigmentation or darkening of the skin, because erythema or inflammation of the skin exposed to the sun is going to be translated into what the patients call scars, but it's not scar, is discoloration. So for example, in a Hispanic patient, you have perioral dermatitis, which is just an inflammatory condition that happens in many different ethnicities, and it's described by bumps around the mouth. Well, those bumps around the mouth in a Caucasian patient might mean nothing, and just a treatment with a little bit of doxycycline will be enough. However, in that Hispanic patient, skin type 4, it means that she is going to also have the bumps and the discoloration, and there's going to be some semi-permanent residual of that condition. So treating it early will prevent that patient from having a permanent discoloration. And then we get other conditions like hidradenitis suppurativa. You know, let's talk about inflammation. That's major inflammation. That's not only inflammation of the skin. We're talking inflammation of the internal organs. You know, hidradenitis suppurativa is that condition in which there is a blockage of many of the sweat glands in different areas like the axilla under the armpits and the groin, and it could also be in the face. And it's associated with severe, mild, moderate, and severe inflammation. Those patients have can have permanent damage to those areas. Well, not only that, they can also have comorbidities. And what are comorbidities? They can have high blood pressure, they can have depression, they can have increased chances for having heart attacks. So addressing that inflammation is very important in preventing that patient from having other conditions of more escalating importance.
So I really like the fact that you focused on the word prevention. And I think as experts in skin of color, we're all here to really serve our patients and treat their skin disease from as early of its onset as possible to prevent a lot of those long-term complications. And I think this is particularly important because we think a lot about long-term complications just on the skin. But as experts, we know there can be complications within the body. You mentioned some of these diseases, both something less inflammatory, like perioral dermatitis, that a lot of patients confuse as just simple acne, which we know it's not, to something really severe and disfiguring, and a lot of systemic implications like hidradenitis suppurativa. One of the things I think we should also talk about is how the skin sort of feels when you examine the skin, not just what we look at, but some of the morphologic changes. And I think, Dr. Alexis, you've seen lots of patients that have changes not just visually, but also texturally in terms of their pattern. Can you comment a little bit about that?
It sounds cliched, but in many ways, the skin is a window to one's internal health. And I think one of the most rewarding things that we get to do as dermatologists, be able to see an actual sign on the skin or the hair or the nails and make a diagnosis of something internal. So to your point about texture, I can think of some recent examples from my practice. I recently saw 2 patients back to back who presented with light patches on their face. They were previously diagnosed with vitiligo, another condition that could present with loss of pigmentation. But it was only after actually laying my hands for examination, so palpation of the lesions, that I noticed that in addition to the discoloration, there was a hardening of the skin. I asked the patient to open her mouth completely. She couldn't because the skin around her mouth was so tight. I looked at her hands and her fingers were tapered, and the skin on her hands was also very taut and bound down. I could not pinch the skin. I asked her about whether she's sensitive to the cold, and she admitted that her fingers turn white in cold temperatures. So all of this together, as dermatologists, we understand that these are signs and symptoms of an autoimmune connective tissue disease called Scleroderma. So with seeing all these signs, I performed a biopsy, confirmed the diagnosis of Scleroderma, and now have her partnered with a rheumatologist who's managing her condition as a whole, with me managing the skin. And that's a perfect example of how the skin can present with changes that suggest internal conditions, but also the importance of palpating, not just looking from a distance, but laying on of hands and assessing changes in texture.
And I think that example also really highlights how important it is that other physicians and the healthcare community realize that we as dermatologists, particularly those who are experts in skin of color, really do collaborate with our physician colleagues in lots of other specialties to really help save patients' lives and to improve their outcomes. And I think that's a great example of collaborating with a rheumatologist, with their internal medicine doctor like you did. And I think we all do that on a daily basis. And I think it's really important that our patients with skin of color know that there is help for them, similar to what you described. One of the things you touched on was the nails, and I'm glad you mentioned the nails of that patient, because I think we always talk about the cutaneous surface, but we sometimes neglect discussing a little bit about skin signs of systemic disease with nails and hair. Dr. Bhanusali, can you comment a little bit about some of the hair cases you've seen, particularly that are linked to internal disease potentially?
Sure, and with forgiveness to your comment, I actually think the hair is the window to the soul more than the eyes and the skin. Look, I mean, here's the thing. A lot of times we like to think everything is okay, and we neglect the signs that our own body is telling us. And that's one of the worst things we can do. Listen to your body. Your body's there to help. It's going to tell you if something is off. I had a patient recently. She came in, I don't know, maybe a few months ago. She had rapid hair loss, and her skin was getting drier and itchy, and you can have something called telogen effluvium, lots of reasons why, but we couldn't figure out what was going on. There was something off. So I had her go to her PCP, do some blood work. They found some abnormal things. Long story short, she just came in after a double mastectomy because she had breast cancer. What was the initial signs? Her seeing a dermatologist because she was worried her hair was thinning. I think a lot of times we neglect little clues that are there. And as dermatologists, what we really do is we're detectives, and we have to put these clues together, and we're here for our patients. It's important to see a board-certified dermatologist because there's an expertise there that can help guide the patient and get them, hopefully, if something is wrong, diagnosed early, and it can get them better. I had a recent case as well. Multiple cysts. Cysts are common. We see it all day long, popping pimples, all that. But a lot of them had kind of come up at once. And there's a line back in a textbook where there's a linkage between some gastric issues and cysts. I had the patient go to a GI doctor, gastric cancer. And so this is somebody who was like 28, 29 years old. And their life may have been saved by just going to see a dermatologist because they wanted to get rid of these little bumps on their body. So again, I think, you know, sometimes we forget that we need to act on signs, and we sometimes tell ourselves it's okay, it's okay, it's okay, but you know, it doesn't take much to go see a board-certified dermatologist, and we're here to help. And that's the best advice I tell everybody is just don't wait, go and find out and get the peace of mind.
Absolutely, and I think the importance of seeing a board-certified dermatologist is something that really cannot be stressed enough, particularly if you have a board-certified dermatologist who specializes in skin of color like we all do. I think that's an added benefit to these patients, and we are the detectives. You're exactly right, because we can help save lives. I know I've had patients, for example, who've presented with what looks like psoriasis. I had a gentleman recently in the 7th decade of his life, new onset eruptive psoriasis all over the body, not responding to traditional treatment. Malignancy workup was done because it was really kind of strange. He wasn't getting better. Turns out he has widespread prostate adenocarcinoma as well as a gastric tumor, and has a rare condition called Bazex Syndrome, which really looks like psoriasis, as you all know, but is due to an underlying malignancy. And I think being the detective is really how we're going to be able to save a lot of lives. And for our colleagues in the outside healthcare community, outside of dermatology, hopefully this is an opportunity for them to collaborate more with us, because I know we encourage collaboration with other board-certified physicians as well. One of the things you mentioned is checking lab work and checking for other sort of signs of inflammation in the body. Dr. McKinley-Grant, can you comment a little bit on that in terms of investigations that we can do that may be better able to help our patients?
Yes, I think often we will start as dermatologists almost knowing what the diagnosis is. The patient walks in and it's like, okay, well, we have to figure out the why of it. So that's where your blood tests come in. But also you want to get the past medical history and the medications that the patient's on, and the family history of different diseases too. And I had a case similar to yours as an intern in internal medicine, and and that's what made me go into dermatology, because the patient came in with a cyst and had Gardner's syndrome, which is a cancer, and we did tests for that, and I said, wow, dermatology is really, really a good specialty to be in. But the tests that we do it depends on what the condition is. So let's say someone comes in with a photodermatitis, which is sensitivity to light, then we might go more towards autoimmune workup and look at anti-nuclear antibodies and blood tests. And we do that also for diabetes. You know, we're checking for diabetes too, but we're looking at other autoimmune skin diseases like alopecia areata, just general hair loss. We will do blood tests to test for that. Then skin biopsies are something very important that helps us differentiate tumors versus inflammation, and it gives us more of a definition, and we cannot live without dermatopathologists.
That actually brings to my mind, you know, as dermatologists, we see a lot of patients with atopic dermatitis, okay, eczema. And we all know that, well, it's dry, itchy skin. Well, dry, itchy skin in those patients is not just dry, itchy skin. They have an immunological condition. They have an unbalanced immune system. They have an unbalanced quality of the skin. There's not the right types of the ligands or the things that cement the keratinocytes. So there's a systemic component to that patient that has eczema that is very complicated, and is not just dry, itchy skin. Some of those patients actually can even have, and if they could be patients, early patients of cutaneous cell lymphoma, because they might manifest themselves the same way is dry, itchy skin, red, dry, itchy skin, but you can even have a lymphoma that manifests. So as a dermatologist, a board-certified dermatologist, we are very powerful in differentiating just dry, itchy skin with other diseases that are systemic and very important to treat to prevent death and complications.
And I have patients who are, let's say, overweight, and they come in with moisture under their breasts. We call it Intertrigo. I will check for diabetes and check for, and often, more often than not, they're early diabetics or some undiagnosed diabetes.
And
so,
I'm glad you brought up diabetes, because I feel like we could spend hours here talking amongst this group about things that are really rare in skin of color and things that are really common, and we have a whole breadth and a spectrum of these things. But diabetes and thyroid disease and autoimmune disease and inflammation, would you agree that those are kind of the four big categories of broad diseases that we see that can affect the skin, of course with more nuances? The one other thing I was thinking about is medications. I know all of us prescribe medications and we manage patients with lots of morbidities. I know I've seen patients who are just on simple blood pressure medicines who come in with sunlight sensitivity and darkening of their skin, which is drug-induced hyperpigmentation. And a lot of times I have to pick up the phone and call that primary care physician and say, can we switch to another type of blood pressure medication because this person is having a rash from this one? Do you have any examples you can share, maybe Dr. Alexis, that you've seen patients who have had these sort of things as well?
Yeah, it's a great point, and I have the exact same example, but I'll just add a little bit more specifics to this one patient. Patient on a blood pressure medicine has dark patches on her face, has been treating the dark patches on her face with all sorts of skin lightening products, some that she's picked up on her own, some that have been recommended by other dermatologists. But the part that was missing was that this was more than just a pigmentary issue.
Right.
This was not melasma. It was, the culprit was her medication for her blood pressure. So only after considering that diagnosis and even doing a biopsy to confirm and stopping the medication did she get better. So that's an example of where you do have to take a step back and think about the whole patient, including the medications that they're on, and asking yourself, could the medications be causing the
Right, and I
skin
think Dr.
change?
McKinley-Grant mentioned the medical history, the medications. You talked a little bit about past family history as well. You mentioned also looking at blood work. I like that we're all talking about skin biopsy here, because I think that is something for our patients and for the public that I think gets a lot of negative connotation when you hear the word biopsy. I have lots of patients who have darker skin types that come in to see me, and I say, oh, we need to do a biopsy and take a small sample of your skin to really test to find out what's going on. And patients sort of get really scared about the scarring and the dyspigmentation and what the side effects of that biopsy are going to be. But as you mentioned very eloquently, a biopsy is a huge part of our therapeutic workup, and a biopsy may be needed. Do you have any tips or pearls for patients, maybe, Dhaval, that you can share about how you counsel patients with darker skin types that doing a little skin biopsy is part of that detective work, and it's okay to do that? You know, we really want patients to feel comfortable that this is part of what we're doing to investigate.
Sure, so a couple things. So one, I tell them it looks better once it's clear than anything we do without treating it, so you might as well get the biopsy because then we'll get overall improvement. You know, the beauty of all this stuff is that we're not just trained in singular modalities. We know clinically, cosmetically, how to treat things as well. If there's a scar somebody doesn't like, we can actually treat that as, you know, that's an issue we can do. But at the core of it, you know, skin of color is a little bit more complicated. Nothing presents how it would in, let's say, a textbook. And sometimes you do need to do the biopsy to uncover why something isn't getting better, or to again, put these clues together to solve this mystery that's going on. And you know, it's kind of like trying to drive blind sometimes, and you can assume and you can do this and that, but sometimes you just need that knowledge. And there's no more definitive way than doing a small skin sample, and at 2 millimeters or 3 millimeters or even 4 millimeters, really, is it going to make that much of a difference? Cosmetically, no. And it's one of those things where it can really change the outcome of how you do, how quickly you're treated. And honestly, the risk and the benefit, it's a no-brainer.
And I completely agree with you, and I think that's a great way to put it, that if it does leave a scar that the patient's unhappy with, we're the dermatologists, we do have a way to maybe make that better. So I think that's a great way to sort of pivot, and I think what we really want to do here, I know with this group, we all agree that we want our patients to feel comfortable and empowered when they come to see a board-certified dermatologist, especially those of us who specialize in skin of color, that we really want to do what's absolutely necessary, but also what's needed to be done to make the patient better and make them feel better. One thing we didn't talk about, but it's been alluded to by all of you, is autoimmune disease. I think seems to be on an increasing trajectory. I feel like I see so much more autoimmune disease in my practice. Lupus comes to mind as one of the big things in skin of color that can be both cosmetically disfiguring, but also life-threatening. I think we've all had lupus patients. I know I've had several lupus patients who've passed away from their lupus. And for some reason, the prevalence of this disease continues to rise, as do other autoimmune diseases. Lynn, can you maybe talk a little bit about your experience with lupus?
Yeah, it is on the rise. It is genetic, though, too. I think there really is a good family history. And then we have a lot of drug-induced lupus that doesn't necessarily get better by stopping the medications. And some of the hypertensive medicines can cause drug-induced lupus. And you really do have to look at that and test for it. There's special tests that you can do. It's interesting, some of the medications, I mean, they just came out with a lupus drug that's a few years ago, but they hadn't had any new drugs in, I don't know, 20 years or something, they said. So it's an area where there's still more research that needs to be done, and early detection is important, and understanding different types of lupus are important, because there's a lupus just of the skin called discoid lupus. But then you get systemic lupus, and you get the subacute cutaneous lupus also. So it's important to work with the rheumatologists with this, because they're pretty good at it. Yeah. So I always work with the rheumatologists with my lupus patients.
And I know we've also talked, all of us in our previous discussions, and I think some of us even published together on another condition that, though different, kind of parallels, which is sarcoidosis, that affects so many of our patients with skin of color. And I know that I've diagnosed sarcoidosis in a patient before they've ever seen any other doctor, and we were the ones who diagnosed it. I'm sure all of you have come in and seen patients who have had sarcoidosis, which again is also autoimmune. I know I've had some Hispanic patients in my practice, Dr. Perez, like you, who've come in with just mild scaling of the skin, sort of what's called ichthyosiform sarcoidosis, where the skin just looks dry and scaly, but you take a biopsy, as you mentioned, take a small sample, a 2 or 3 millimeter, and the biopsy shows inflammation everywhere. Can you comment a little bit about sarcoidosis and what you're seeing right now in trends?
Actually, sarcoidosis is a great example of utilizing the skin as the window to make an internal diagnosis. For example, we have lupus perennius. We have those little purple papules around the nose, in the cheeks, and the patient just comes, they're totally indolent, nothing happens to them. And unfortunately, if you do the biopsy and you make the diagnosis, that patient can be at risk of having pulmonary sarcoidosis, pulmonary fibrosis, and compromise of his or her life. So just by knowing all the manifestations in the skin of sarcoidosis, you will be able to help patients get an earlier diagnosis and get treated and preventing complications.
That sort of reminded me about the importance of nutrition and exercise and fitness and overall well-being. And I think there's so much emphasis in society and in social media. I know you're an expert in the overall skin health of patients and wellness. Talk a little bit about diet and nutrition and how that plays into what we're talking about in skin of color.
Sure. Honestly, it's a very interesting time, and it's a kind of a fun time when looking at nutrition. There's a lot we don't know, and always honest about that. But we're starting to see different connections. A lot of published studies with vitamin D, let's say, in patients with vitiligo, who, if you improve their vitamin D, their vitiligo starts getting better and responds better to treatments. I think with hair, there's certain numbers I look for that might be a little bit above normal, that my hair patients tend to grow hair a little bit better. I think, as time will kind of mature, we'll be seeing that every patient's a little bit different, and maybe their nutritional kind of guidance is slightly altered, but there will be certain suggestions coming through, and I think as we get more into the whole like signature therapy, personalized therapy, that would be a big aspect of how patients are treated and cared for. Psoriasis is another great example. The anti-inflammatory hasn't held yet diets. But there's something there where there's some sort of dietary change can help these patients. And we're just now scratching the surface, no pun intended. But as we learn more about it, it's very exciting. And I think, you know, in a world where certainly we have a lot of great medications for patients, topical, oral, systemic, injections, it'll be great to have another option for them that perhaps can reduce the amount that we need for them. And that's part of the exciting breakthroughs that I think are coming soon.
And my conflict of interest to your comment is that I love pigmentary disease. I focus a lot on vitiligo in my practice, and you're absolutely right. For my vitiligo patients, all of them get a handout and a prescription, quote unquote, of oral antioxidants and some dietary supplements we do recommend as part of their treatment. And sort of the blood work aspect and the investigations that you talked about, I think we check a lot of those for a lot of these diseases as well. So, you know, we're really focusing not just on what we're seeing outside, we've talked about investigating inside, and now we're talking about really rounding out the patient holistically. And I think that's a really neat aspect of where we're going in our skincare journey as dermatologists.
I think also with the obesity and the weight loss, you know, people focusing on their weight now. So we get the people, men and women, who over diet, you know, go on, become anorexic, or they're going to lose hair, they lose nails, they get brittle nails, they're, you know, become malnourished. They will get severe telogen effluvium from dieting. On the other hand, the obese patients get other rashes and develop diabetes and heart disease. And then our patients with inflammation of the skin, the psoriasis patients, and as we talked about, are more prone to heart disease too. So it's all has to be put together.
And to put it relevant, you know, it's very simple. For example, a few years ago, there was a study that was published in the New England Journal of Medicine. I think it was an Australian study, and they demonstrated that niacinamide, vitamin B3, has an impact into the sun protection of our skin. So you can actually give a vitamin to your patients that will protect them from progressing into skin cancer. So that is a real impact. And it's such a simple intervention. It's just vitamin B3, 500 milligrams niacinamide twice a day.
I love that, Pearl, and I like the fact that you focused on simple. And a lot of times we know that we don't have to recreate the wheel and make things super complex. Sometimes it's the most simplest pearls that we can provide from our wisdom and collective experience that the patients can really benefit from the most. As we close out, any final thoughts on take-home messages for the public, for our other colleagues in medicine, for our patients? Dr. Alexis.
To me, the most important message is that changes in skin color or presentation of changes in skin texture are not to be dismissed as something that's just skin deep, if you will, and can be treated with moisturizers and creams and serums. They should be taken seriously, and I would urge the public to, when they see changes in their skin that don't go away with normal remedies, not to sit on it, but see a board-certified dermatologist.
Great. Dr. Bhanusali, any last final words?
Similar. I think I'm a big advocate. Doesn't matter skin tone, you should get a full body exam every year. I think by getting a full body, it's not just the perhaps looking for a skin cancer or something like that that you may get benefit from, but it's also you might pick up things and things that you might not notice, slow-growing things, whether it's the acanthosis nigricans for diabetes or just more systemic type changes, fatigue, itchiness, all these kind of things. And again, as echoed earlier, the body gives you all the hints, right? You have to act on them. And your friendly board-certified dermatologist is there to help. We're all fun, and you know, hopefully it's a great experience. But truthfully speaking, the doctor's office, again, people get scared and nervous too, but we're there to help. And I think, again, when you have this little cheat code where the body's showing you, it's in your best interest to act.
I think so too. Dr. Perez?
Actually, and let's not forget that we board-certified dermatologists not only are good for diagnosing, we're good for treating. We take care of the whole situation. We take it from making the diagnosis, talking to our colleagues about intervention, but we also treat our patients. We can treat our patients with lasers for pigmentary disorders. We can treat our patients for skin cancers. There's a specialty called Mohs surgery, and Mohs surgeries, most of them, or 95% of them, are dermatologist, is your board certified dermatologist, can take it from the beginning to the end.
I love that. It's a journey, and we can guide you on that journey. I love that. Dr. McKinley,
I think
go ahead.
one thing for physicians and for patients is that we need to use all 6 senses to make diagnoses, treatment, everything, to take care of our health. Now, we say 5 senses, but we don't have to use taste, but you do have to use touch, sight, smell, and then your 6th sense about what's going on, and because you know your body the best. I would encourage patients, when they see something that's wrong and the physician can't see it, to make the physician touch it and then see it. Just be very assertive about the care that you're getting.
Well, I think this has been fantastic. We've covered everything from malignancies and cancers to inflammation to diabetes, thyroid disease, a whole breadth of topics. And I hope what this really shows our public and our colleagues is that we as board-certified dermatologists who are specialized in skin of color really have a truly unique expertise to guide a patient from their origin to their destination in their healthcare journey, and particularly in the skin, hair, and nails. This has been a great opportunity to discuss with these fantastic leading experts on skin signs of systemic disease, systemic malignancy, and I encourage patients, the public, and our healthcare colleagues to visit skinofcolorsociety.org to learn more about what we're doing as skin of color dermatologists in the healthcare setting.